Okay, so I can still see we've got some people coming in, but we've got lots of really fantastic information to cover today. So I'm keen for us to kick off and get started. So welcome everybody, and it's fantastic that you've been able to join us for today, our third session in our Health Equity in Action webinar series, From Equity to Impact. And today's session is around improving outcomes in physiotherapy. My name is Claire Atack, and I'm a professional advisor here at the CSP, and I'm also part of the CSP Health Inequalities Project team, and I'm one of your webinar co-chairs today. I'll hand over to Kat, who's our other co-chair, to introduce herself.
Hi everybody, and welcome to everyone that's just joining. My name's Kat Lawrence and I am Research into Practice Advisor at the CSP, and we'll be helping to co-chair this webinar today with Claire.
Fabulous. Next slide please, Sarah. Great. So as always, before we get started, just some really quick housekeeping. Just to say to everybody, this session is being recorded today, and it will be available to rewatch and share, initially through our Health Inequalities ICSP, but then hopefully by the end of the month, it will also be available through our CSP Health Inequalities web pages, and I will signpost you to those further on towards the end of the webinar. Because there are quite a few of us in the room today, which is fantastic, we're going to keep cameras off and mics muted for the audience, but we do absolutely want to hear your questions. So I'd like, we're going to ask people to use the Q&A function, which is up at the top bar, to ask your questions. Please feel free to use the chat for any kind of technical questions, and we'll be popping some pertinent resources into the chat as we go. But questions, please, in the Q&A, and we'll get through as many of them as we can. But if you see questions in there that you would particularly like some answered, then please do give them an upvote, and that will really help us to prioritise as we go through the session. Next slide, please. Pass on to Kat.
Thanks, Claire. So before we get started and hear from our speakers, we thought it might be helpful to set the scene from the final piece in our CSP Health Inequalities Frontline series. So our final article highlighted a simple but powerful truth. Equity isn't just an abstract ideal, but it has a measurable impact on recovery, well-being and service performance. So when barriers such as work patterns, childcare, language or past experiences are not addressed, they don't just shape people's access to physiotherapy, they shape their outcomes as well. So two patients could start the same rehabilitation programme with the same condition, yet their progress may diverge dramatically, not because of difference in motivation or attendance, for example, but because the system fails to meet both individuals where they are. So today we come together for the third webinar in our series, and it builds on earlier work exploring unequal access and experience within physiotherapy. So while getting people through the door and ensuring that they feel heard are essential first steps, the real impact of inequity becomes visible in our outcomes. The message is clear. Equity is not just an add-on, it's a core driver of better care and better outcomes. So when services are designed and delivered in ways that recognise people have real lives, everyone benefits. Patients recover better, clinicians can work more effectively, and systems become more efficient. So today we're joined by 3 spotlight examples who will kindly share how improving people's access and experiences has led to better outcomes, not just for their patients, but also for their services and even their own work-life balance. So without further delay, I'm delighted to hand over to our speakers who will take this discussion further and explore what equitable practice looks like in action. So up first, I'm delighted to welcome Emily Fender and Emmy Peck, who join us as Healthy Living physiotherapists from Guy's and St Thomas's NHS Foundation Trust. So thank you, Emily and Emmy.
Thanks, Kat. Lovely. So myself and Emmy, like we've just been introduced, are in the weight management service at Guy's and St Thomas's, and we will be discussing our men's only weight management programs that we have developed. Next slide, please. And next slide again, please. Lovely. So what we'll do today is I will give you a brief introduction of what our Tier 2 weight management services include, and then we'll go over the problem that we identified for men living with obesity and what we have done to address the health inequalities. Please, next slide. Brilliant. So in terms of what our Tier 2 weight management service includes, is a 12-week program. You have one session a week, and that is an hour long. Within these sessions, what we do is 1 week we have education and discussion topic, and then the next week we do exercise. And it's all based around behavior change techniques, aiming to achieve a 5% body weight loss. Next slide, please. So what was the program that we identified? So in 2022, 67% of men were overweight or obese, yet only 25% of participants referred to our Tier 2 programs were men. This shows that overwhelmingly referrals are mostly women dominated. And interestingly, when looking at GP referrals, 9 in 10 referrals from GPs to weight management services were for women only. This is interesting because it demonstrates and shows insight into the way that men behave, I guess, with healthcare, but also how healthcare behaves and interacts with men. There was some research to show that sometimes GPs may feel like, or healthcare providers might feel that weight management services are not suitable for men or aren't fit for men, or they may not be interested. However, there has been papers that show that once they've been referred into the program, attendance is very similar to women. So it's just kind of getting them through the door. This is really critical because obesity is associated with reduced life expectancy and is a risk factor for a range of chronic diseases as well. So if not addressed, it can further increase the gender gap and risk worsening health inequalities for men. Next slide, please. Something that we wanted to bring up was the men's health strategy, which was released in 2025 in November, so quite recently. It was made after we developed our program, which kind of gives and reinforces our vision of making men's only programs, and it supports the reasoning for targeting men specifically in weight management services. But we'd recommend you reviewing the document as it provides a lot of insight into the next 10 years and the vision that the government has for the men's health over the next 10 years, but also actions that we can take in improving healthcare for men and boys. But I'll pass over to Emmy to discuss the development of the men's only programme with you.
The next slide. Thank you, Emily. So we started off our design work with some engagement. We wanted to get an insight from the men that we already had in our programs, our mixed gendered programs, as well as some of the men from Lambeth who we were targeting. We sent out some questionnaires and used a partner that we work with called Food for Purpose to do some interviews with men. And the main findings were that they really confirmed the need for a men's only group for weight management, and specifically Black men wanted a male only program for Black men, so we considered a culturally tailored men's program as well. In terms of the approach, they wanted a really direct, targeted, action-based approach. Didn't want any of the fluffy stuff, was one of the feedback that we got. They really preferred a non-NHS location. So they didn't want to be in their local health centre. They would rather be in a gym, and they wanted more of a focus on strength-based and sports exercises. They were really keen for resources, so going back to that kind of direct prescriptive approach supported with workout plans, meal plans, things like that. And they were keen for discussion around men's health topics such as body image, mental health, and depression. And when we asked them about the gender of the facilitator, there were some mixed opinions. A preference for a male facilitator, but as long as they felt that person was skilled, they were okay. And there's some quotes on the side which just sort of really back up some of those men's insights. So you can have a read of those when this gets handed out later. Next slide. We also did some research, so we wanted to see what the literature said. So this study, exploring the influences on men's engagement with weight loss services, showed that men were normally coming to the weight management programs when they were triggered by fear as a motivator. So from sort of GP health appointments, they didn't feel comfortable in weight management services as they felt they were female dominated. And some of the suggestions from this was to include some humour, lots of physical activity, and more of a sports context. And I also met up with the program coordinator of Shape Up, which is a men's weight management program run by the Arsenal Football Club, which was very helpful to discuss sort of how they had gone about setting up their men's program. Next slide. So this was our final design. We had a few different cohorts run through, so it's sort of gone through a few different iterations, but we've held it at a venue called the Black Prince Trust in Lambeth. As you can see from the photos, it's not an NHS setting, so it's in a boxing gym with opportunities to access a fully functioning gym and activities like walking, football. So we still use our behaviour change approach with the emphasis on getting fitter, stronger and healthier, not necessarily weight loss. That can be perceived as quite feminine. We split the session up, so it's 30 minutes of exercise and 30 minutes of education, so they're getting that exercise in every week to keep them engaged. We've tried to use a male facilitator where possible, and focus on using direct, informative approach. And we have had a guest speaker come in for the men's health sessions, which has gone down very well. We use up the resources such as the exercise plans, healthy recipes, and sort of weekly reflection tasks. So that's a picture of our booklet there as well that we hand out. So that's the group design. Next slide. And then in terms of the feedback we were given, we handed out another questionnaire at the end of each of the cohorts. So the patients who sort of completed gave us feedback. They all said that they were really pleased they participated in the program. They had made some really positive lifestyle changes, which was one of our main aims. They liked being part of a group as well, which was really positive to hear. And they all made some improvements in their knowledge of their diet, their confidence, fitness, physical activity, quality of life. They found the education sessions useful, relevant, and able to utilize them. And they found the physical activity enjoyable, suitably challenging, and they preferred the taster sessions as part of the program. They preferred them the most. So next slide.
Lovely. So I guess we know that there's positive qualitative data. So we had a little look at the quantitative data, and this graph shows weight loss. So what we did was we compared the men's groups to the Lambeth Healthy Weight Mixed Genders group from 2024. And you can see on the right hand side, in terms of those participants that lost weight, there is a very equal split. So 66% in the Lambeth Healthy Weight and 67% in the men's only groups. So you can see the outcomes are very similar for that. When you break it down into subcategories, you can see that men actually had an increased amount of weight loss in terms of between the 2 to 5% of your body weight loss, but actually they had less in the 0.2% and over 5%. So looking at this graph, it does show that preliminary outcomes are positive. What we are limited by here is the amount of data that we have, as the men's groups were relatively small, but it's something that we are looking at going forward, as we know that there has been good outcomes. We want to continue this and develop this going forward. Next slide, please.
To touch on some other outcomes as well. We feel like this hasn't only had good outcomes for the men that have participated in the groups, but also us as a team and our wider team that we work in as well. So for those of us doing the groups, it's really helped increase our learning and awareness around gendered health inequalities, which has then filtered into our team and those who are delivering the mixed groups as well. We're thinking more about when we do interact with men in those mixed groups, how are we sort of adapting our communication style? How are we signposting? How are we sort of challenging those societal norms when it comes to weight loss and men's engagement within that? So it is having a wider impact on all of the men coming through our service as well. And in our wider obesity team, we work with a tier 3 team of dietitians, and they have started a men's group as well. So we've been able to share some of our learning across with them, which has been really encouraging. Next slide. And then we're very aware that there's a lot more work that we can be doing. We've only done, we're on to our 4th iteration of the group, so we've got some next steps for the future. And the men's health strategy has been really helpful in providing some guidelines. So we went through the men's health strategy and picked out on how we can be aligning more with them. One of the things they mentioned was addressing men's health literacy. So there is a discrepancy between men and women's health literacy. So we should be really considering that when we're engaging with men in any sort of healthcare. We would love to partner with proposed neighbourhood health centres that are hopefully going to be popping up soon. We need to be maintaining our knowledge of charities and support organisations specifically for men. I think we're very good at knowing where to send women or families, but we don't know as many of those sort of more specifically focused for men. We want to explore more of our around engagement, and virtual weight management might be an option to help men to engage more. And then finally, just monitoring and evaluating the men's access to services and their health outcomes. So we're currently actually doing an evaluation of our programme so far. So it's good to know we are contributing to that and producing more data. And then finally, we know that we had small groups to begin with. We did have dropouts, and it'd be great to understand and gather feedback from the men who didn't actually complete the programme and find out more about what their barriers were and any suggestions that would have helped them stay engaged. So we've got a bit more work to be doing, but it's been really, really positive and really fun to be involved with. So thank you so much for listening.
Amazing. Thank you so much, Emmy and Emily. That's actually so fascinating to hear about the difference between men's and women's health literacy. That's not something that I, in my practice, have kind of considered before. And it's also really great to kind of see that process that you've been going through and that you're still going through, kind of refining and using all of your insights to just keep looking at transforming your services, really driven by feedback from your patients. And it's great to hear about the wide impacts and the learning that other services are getting for your work. So thank you so much for sharing that. So I now have the pleasure in introducing our second speaker, Katie Napton. Katie is, amongst many things in our profession, she is the founder of PhysioFast Online, and Katie has a private practice where she's a clinic owner and a practicing clinician down in West Sussex. And you're also chair of Physio First. So thanks so much for joining us, Katie. And you're going to be telling us about your work through PhysioFast Online. Welcome.
Thank you. So I want to start really of why my service exists. So PhysioFast Online is physio basically via a video, so nothing wildly exciting, and it didn't come from my desire to innovate digitally at all. It came just from repeatedly seeing people whose MSK problems worsened because care didn't fit their lives. So people were waiting too long, struggling to attend appointments around work or caring responsibilities, thank you, and often deteriorating before they were ever properly seen. So these weren't people disengaging from care, they were people basically being squeezed out of it. So when care doesn't fit life, people fall through the gaps. And that's not a marginal issue, that's an equity issue, which is why I'm here. Next slide, please. So when I talk about personalized care, I'm not talking about optional extras or luxury. This isn't it's not luxurious in any shape, way or form. I mean, having that time to listen, continuity with the same clinician, and understanding that wider health context, work pressures, caring roles, financial stress, and fear about what that pain means for that individual's, their job or their livelihood. So we work on care plans that are developed with patients, not simply prescribed to them, that shared decision making is what drives engagement and follow through. And obviously we link in with other specialities too. So personalization isn't indulgent, it's how physiotherapy becomes effective in the real world. Next slide, please. So access is often talked about as whether a service exists, but that's really only part of the picture, isn't it? The real question is whether someone can realistically use it. So digital first or remote physiotherapy removes some very real barriers. So that's travel, time off work, childcare logistics, and repeated missed appointments. It also, for some, has some barriers. I appreciate that. But for certain groups, it's particularly important that if they have funny shifts or high pressure environments, so including groups like prison officers, where that face-to-face access is often tricky or virtually impossible. And so one of my major contracts is with prison officers, all the Justice and Immigration Service people. So if someone can't realistically attend care, the care might as well not exist. Next slide, please. The joy of being a small independent provider is that, I don't have the same scale or mandate as the NHS. And so we can easily monitor effectiveness and respond quickly to what outcomes and patient feedback tell us. Accountability is much more immediate. Outcomes, engagement and feedback directly influence whether a service continues or not. So my contracts are reliant on actually getting the results. So monitoring and learning have to be built in from the start. So for one of my big contracts, I've got a Power BI dashboard set up, and we're having to evidence that we are, getting significant return on investment for the company. So it's not really claiming certainty at proof or scale. It's about being responsible, reflective, and willing to change, and the ability to change when something isn't working. So I think having that accountability really sharpens the focus on what genuinely helps people recover and stay engaged. And, in terms of this, it's keeping them at work or getting them back to work quicker. Next slide, please. So I think, hopefully all of us see that, our role isn't just about treating symptoms. We use physiotherapy as advocacy. That means helping patients understand the condition, supporting conversations with employers, and enabling reasonable adjustments so recovery is possible without risking livelihoods. And so actually following on from that previous talk, we do engage with dietitians, we engage with mental health workers. We need to look at the bigger picture. And for many that have accessed our service, physiotherapy has been the first place they have felt heard, believed, or listened. And I think that really, really matters and is hugely rewarding. The other issue that I've discussed often is that, independent services don't replace NHS care. They complement it, filling in gaps and supporting people who would otherwise be left behind. So currently the service that we run is a 7-day-a-week service running from 8 till 9 p.m. So people can choose appointments that fit them. And finally, when physiotherapy is accessible, personalised and accountable, it protects more than physical health. It protects participation, work, and quality of life. I feel hugely privileged to treat the people I do and my team. And the feedback we get is, really, really valuable. Thank you.
Thank you, Katie. It was really great to hear about kind of virtual physiotherapy and that shift, and particularly your reflections on how that works in the independent sector and your experiences of the kind of different organisations or the different contracts that you've held in terms of, especially for me, the justice sector. So thank you for sharing your experiences. And also highlighting the importance of remembering that the NHS services and independent services should complement each other. And really, our overarching aim is to improve equity and in terms of people accessing care when and how they need to. So thank you. A reminder, for any questions, please pop them in the Q&A, and we will come to those in the discussion section. I'll now hand over to George McMee, who is a senior lecturer in physiotherapy, therapy placements team lead and clinical specialist physiotherapist. So thank you, George.
Thanks, guys. Just going to share my screen with you now. Lovely. Kat, can you just confirm that that's all working okay?
Yeah, we can see that. Oh, yes, we can see that now.
Awesome. Brilliant. Thank you. Yes, a really real privilege to be here to share this work with you all today. So I'm come from a background of a split role in education and within a clinical role. And just going to share some of the work that the team and I have been involved with trying to break the cycle of persistent back pain and inequalities. So for those that kind of aren't coming from an MSK background, research shows us that about 84% of people worldwide will experience low back pain at some point in their lives, which makes it the most common MSK problem and the leading cause for disability, lost productivity and income poverty, not only in the UK, but worldwide. Now, we're based in Coventry, and just to give you some outline, Coventry very much kind of sits along this trend within the UK around similar levels of people who experience back pain and high impact back pain. Now, what we see is that there's an increased prevalence in higher areas of deprivation and that there are then inequitable access to care across the region, but it also costs our health system a huge amount of money. Now, when we look at back pain, we know that people who are more likely to experience these symptoms come from areas of deprivation or from lower socioeconomic status. We know that people from minority ethnic groups and those that have lower educational attainment are also more likely to experience back pain, reported at about twice as likely for the ethnic groups. But we also then know that you're more likely to have back pain if you live with multimorbidity, that being one or more other long-term physical or mental health condition, but also have poor or kind of unhealthy lifestyle behaviours. But what we know is that the current model of care is not necessarily set up to allow for positive impacts for these people. For those that don't respond to primary care interventions like self-management, education, and pharmacology, they often go through a low-value tier of imaging, injections, surgery, and opioids before getting to the level of kind of multidisciplinary or combined physical and psychological pathways that are recommended in the research. Now, we're incredibly fortunate to have come across an intervention called cognitive functional therapy. Now, CFT, as I'm going to kind of coin this for time purposes, is an integrated behavioural approach for individualising the management of persistent low back pain. It aligns to best care principles and clinical guidelines through using a multidimensional clinical reasoning framework that allows us to ensure our intervention is person-centred, biopsychosocial at heart, and a behavioural approach. It follows three key principles of trying to facilitate a patient in making sense of their pain, looking at exposure to feared, painful, or avoided tasks or movements, aiming with control, but also then building in healthy lifestyle habits. And what we know is that CFT has been shown in a recent systematic review to be the most effective tailored treatment to reducing pain intensity and disability for low back pain. And if we look at the largest multi-centre RCT, we can see that the clinical effects that have been sustained with CFT are sustained at 3 years, which for any of you that come from a pain research background doesn't happen at all. So firstly, it's incredible that the team have followed this group up at 3 years, but to sustain those effects is really, really promising. Now, the key limitation to this to date is that we didn't really know whether we could deliver CFT within the NHS. It comes from an Australian group predominantly, but has also then been trialled in Ireland, Denmark, Norway, and in other areas. So one of my colleagues, Chris, undertook his PhD looking at whether CFT could be delivered within the NHS. And what he found was that it was feasible and acceptable to both physios and patients, and that we can train physios to deliver CFT to competency with fidelity. And we saw improvements in pain and disability among a wide range of other outcomes compared to usual physiotherapy care. So we went through a funding round. So we were successful in securing a Wave 3 population health management bid within a local ICB to embed a population health project within our MSK physio service in the NHS. So we led a recruitment drive, so project leads, a GP, some physiotherapists, who we then trained to deliver CFT. We delivered this intervention to 61 people, and I'm here then today to share you the evaluation of this. So one of the really important things for us was to understand who we need to include in our project. So we undertook a scoping review of 108 RCTs on a global scale that looked at evaluating physiotherapy interventions for back pain. And what it showed us is that people at higher risk of persistent and disabling symptoms either don't participate in or are excluded from RCTs. When we look at this from an ethnicity perspective, excuse me, there was less than 25% of participants in these RCTs coming from minority ethnic groups. And over a fifth of the RCTs required participants to understand the native language of the country that this RCT was hosted in. Considering multimorbidity, we know back pain's multimorbid. However, what we saw within these RCTs is that more trials excluded people with mental health conditions than for any specific spinal pathology. And less than half of the RCTs assessed participants' psychological profile, which goes against clinical guidelines. If we then look at the socioeconomics, less than half or just under half of the participants had higher education qualifications, which doesn't match our population here in the UK, or in fact, most of those globally. And also, bearing in mind, one of the first things I shared with you was that back pain was a leading cause of work absenteeism. 80% of participants were employed and only 10% had low back pain related work absence. So it really doesn't mismatch. And what this really told us is that our study needed to adopt strategies to ensure participants were representative of those living with low back pain. So building on this and working with the NHS Core 20+5 model, we chose to include people with persistent low back pain who came from the 20% most deprived area of Coventry according to IMD level. They had to have at least one other long-term physical or mental health condition. They had to be prescribed medications that were not recommended by clinical guidelines, and they had to have reduced workability. Now, whether that's that they're off work, currently unemployed, or at risk of being off work due to impaired function, we class that within this category. So just to give you a picture as the group of people that we explicitly targeted within this project, we had a greater number of people who are from minority ethnic groups, including 25% who didn't speak English as their first language, so a hugely diverse population. We were really pleased to see that just under half were unemployed, so we really felt that we were kind of approaching and tackling the right people. For those that were unemployed, 96% attributed this inactivity economically due to the low back pain. And for those that were in employment, 70% had had work-related low back pain absence, which again really does marry up and reflect the original statistics I shared with you. On average, the people that we saw had had back pain for 9 years, and interestingly, they had 7 other pain sites in their bodies. They didn't just have back pain. On average, had 5 other comorbidities, which included other MSK problems, and well over half having mental health problems. So it was really important for us to capture clinical outcomes for this. But we know, and I'm sure a lot of you can relate to the fact that to try and get anything through a health service at the minute, there has to be a kind of narrative around the economic impact or service utility. So we also then made sure that we looked at this as part of our evaluation. So to share our outcomes with you, we saw statistically and clinically meaningful reductions to disability levels and to pain intensity. We saw significant improvements to workability, and we also saw a huge increase to the amount of people who rated their symptoms as acceptable. When we look at healthcare utilisation, firstly, we looked at healthcare contacts. Now, this was any healthcare contact. They might have been to see a pharmacist about diabetes medication or a podiatrist about an ingrown toenail. We looked at everything, and these total healthcare contacts and associated costs reduced by 34%. If we narrowed this down, just looking at the contacts and costs for low back pain specifically, these reduced by 81%. And we also saw that prescription medications reduced by 81%. To narrow that down for you, nearly 90% of the people that we saw were taking opioids when we first met them. And by the end of us intervening, so at this six-month mark, 37% of opioid users were off this medication. If we then look at work absence, the societal impact from this. So I'd mentioned earlier on that 71% of those in employment had had work-related absence because of their back pain. And if we look at how many days that accounted for, in the 3 months, that was 41 days. So we're looking at 2.5 weeks absent because of back pain per month. This reduced at 3 months, but the interesting data here is at 6 months, where only 18% of those in employment were reporting back pain related absence. And in total, that would reduce to less than 2 days per month because of low back pain. So a huge, huge reduction in work-related loss. When we look at societal loss, so taking account for productivity loss and employers' loss, at 3 months, we saw a 24% reduction in these costs. And at 6 months, we saw over 50% reduction. And what this means for the health service. So we looked at participants' self-reported health ratings and then managed to convert these into cost savings for quality adjusted life years. What we saw at 6 months was per person, per quality adjusted life years, that we were able to save the NHS £2,500. Now, to give that some context, NICE consider a cost-effective intervention to cost £20,000 to £30,000 per quality adjusted life year, not to save money. So what we have here is a hugely cost-effective intervention. Now, I know it's important for us to share these statistics, but more importantly is to hear the power of what this means to the patient. So we managed to secure some money to put together an educational video to support this project, a little bit of which I'm just going to share with you today so you can hear what the patients thought of this.
Through taking a broad approach, patients tell us that they can get better, that they have more hope for the future, and they're able to engage in the things that they value and enjoy doing in life.
I feel like there's hope. I feel like I'm getting fitter, I'm doing more, I'm kind of going to the gym, I'm doing swimming, I'm eating healthier, my outlook on life's a lot better. Now I'm doing these things and I actually feel like I've got a really good outlook in life.
I've got my life back. I don't think of myself as somebody with a back problem or back pain. I run, I do my martial arts, I walk, I just there isn't anything that stops me apart from my own laziness.
So that's just a short video of an educational, or a clip of an educational video that we put together on our self-care website. So please feel free to check that out. But in the kind of hope of trying to improve accessibility to care, we've also then translated this into the 7 most commonly spoken languages in Coventry. And we now know by census data, this means that 92% of our population are covered, and we know that they are able to access and understand this important information. So what makes what we've done unique? Well, we've shown that physios can be trained to deliver high value care. We've not only demonstrated improved clinical outcomes, but also at significantly lower cost than our current pathways. We unfortunately funded this through non-recurrent funding, so we're not able at this point to be able to implement this as standard practice, but it's something that we aim to do. But to do that, we know we need to test implementation across the UK to embed this as usual care. And you'll see from the chart there that we've got a couple of sites around the UK who have reached out to us for training. Now, just to wrap up, there's a few people that we need to acknowledge as part of this, the team behind it being one, but most importantly, the patients. So the 4 people on the left are people who gave up their time and trusted us to communicate their story through this educational video and case clips. One in particular important factor is Maria in the top left, who's a Romanian speaker, who we've managed to capture her story in her native language as well, again in the kind of gist of us trying to make sure that we make sure this is accessible. But also there's community groups who allowed us, who opened their doors to us, to allow us to come in to understand what they wanted from healthcare. This whole project has really been co-created with the people who've been at the heart of this. I'm more than happy to take questions, to reach out and contact, but I've also shared with you the QR code for the Evolve Pain Care Academy, who look at developing training programs for CFT moving forwards. But yeah, thank you very much, guys.
Brilliant. Thanks so much, George. Such a brilliant example of how your work has shown really amazing outcomes for patients and for the service. And something that people find really difficult is the data, and that's a really brilliant example of how you've kind of used your population data with your service data as you've been going to really show that kind of huge impact in a really tangible way. And then obviously the most important thing is using the patient's voice to really kind of drive all of that. So thank you so much. So I'm going to ask all our speakers to pop their cameras on now, because we're going to do our Q&A section, and I'm happy to say we've had lots of questions coming in, which is brilliant. There is still time to add your questions, so please do feel free to have a look at the Q&A section, add in any questions you have and upvote, and that will help me and Kat work out which question to ask. And but I'm going to kick off with a question for you, George, just because you just finished speaking. And so we'd just like to find out a little bit more is how did you train the physiotherapist to deliver the CFT?
Yeah, thanks, Claire. So we're very fortunate that the project leads on this, Chris, Gurpreet and myself are accredited trainers for delivering CFT. So we followed a model similar to the biggest RCT in Australia, the Restore trial, which takes, the only way I could liken it is to taking a clinician on a journey similar to that of a learner driver, whereby they start by gaining an understanding and then look at applying that, but under the guise and supervision and mentorship of a trained clinician. So it involves a lot of mentorship, lives, we see patients together, it involves debriefs, recorded sessions to allow these clinicians to reflect back on their work. So the process takes about 6 months in general, and we kind of check in on a monthly basis, starting at a workshop, then some skills work, and then this mentorship once a month for 3 sessions. But yeah, if people go and have a jump on the Evolve website, they'll be able to get some more information, or happy to chat to anyone that might be interested in looking at exploring that in their own workplace for sure.
Brilliant, thanks so much. And I think the link to the Evolve website is in the chat. Thanks.
So I'm going to come in now with a question for Emmy and Emily. So it's been upvoted. It's quite popular in the Q&A. So the audience are interested to know what funding streams were accessed to support the development of your group. And the comment that these groups are fab, but funding streams are often the main stumbling block.
Thank you. Really good question. I'll take this one. So we're very fortunate, and our service is commissioned by the local authority, so Lambeth, the Borough of Lambeth. We already run some culturally tailored programs, and they loved those, and they were really keen that we kind of do some more tailored work, and were keen for us to do that. So that kind of was sitting within our budget already, from the money that we had coming in from our commissioning pot. But I know it can be really difficult when you don't necessarily have such direct sort of tangible access to your funding. So yeah, that was how we kind of accessed ours.
Thank you. And I think in our previous webinars, we've had similar discussions. And one of the challenges is that it differs from postcode to postcode and different local authority or different commissioners. But thank you for kind of sharing how that worked within your service.
Brilliant. And I've got another question on commissioners, and this one is for you, Katie. And Ryan has asked, what outcomes do you find in your experience commissioners value most?
Well, it's usually work capability, isn't it? So we collect information with regards to, obviously what their current capacity is, whether they're at work, off sick, or working with the issue. And then we also get them to answer whether the service has helped them stay at work or get back to work quicker. So it's that, it's the economics of the whole thing, really. So yeah, it's all about capacity, capability, and getting things going. I mean, so I think, so I'm into my second or is it third year of the current contract that I have. And the first year we evidenced that, for every pound they spent, they got at least £4 back. So the service isn't costing them any money at all. It's only saving them money. And we also look at actually just individual feedback. So most people feel more supported. We quite often run alongside current NHS physio because we're just a named person that they can go back to and ask a question all the time. So it is, when it comes down to the nitty gritty, it's the pounds. So it's the work capacity, but they do look and recognise that support factor and the well-being and general involvement makes a difference too. So it is a little bit of the feedback as well.
Brilliant. Thank you, Katie.
Thank you. So I'm going to jump to a question for George. So how did your team manage and overcome the language and health literacy issues that must have cropped up from the inclusion criteria?
Yeah, so a great question. We're really fortunate that the approach is person-centered. So it's around using a patient's narrative, a patient's voice, a patient's words to help them to gain an understanding of their symptoms and problems. So however they communicate that, we will reflect back in that manner. So we used interpreters for those that didn't feel that they had sufficient English language skills. One of our team is a Punjabi speaker, so he naturally just took the patients who spoke Punjabi. So we did that through our funded interpreters, but also more than happy to use friends and family if that was, again, a patient's preference. This, again, came down to things being person-centered. We encountered a few challenges from a study perspective in terms of getting people to consent and to enroll. So we were the first study within University Hospitals Coventry and Warwickshire to translate our participant information sheets and consent forms. So we did that again to the 7 most commonly spoken languages in our region, which again meant that we could capture around 90, or we would meet the demands of around 92% of our population. This in itself does come with financial challenges. So we made sure that this was within the bid for the project, but again, aligned really well in that we're trying to reduce health inequalities. It made total sense to us to be able to do this for our population.
I have a question now, again, get back to Emmy and Emily. And I'm not sure if this is something that you're doing yet, but it's certainly in your plan. It's a question that says, were you able to contact those who didn't uptake the programme to see what they wanted or expected? Or how, if there's something you haven't done yet, how are you going to plan to do that? Have you got a strategy that you can share?
Yeah, so this has been one of the biggest challenges. I think everyone knows working with people who don't engage can be really difficult, as they tend to just sort of not pick up the phone, not answer messages, things like that. So we do have across all of our weight management services a sort of DNA policy, and we do try and get in touch with people after they don't come to one of the sessions to find out, is everything okay? Do they need to join a different group at a different time? How can we personalize it even more for them? That kind of thing, because we want to really try and we know that we run groups and it can be difficult to personalize things individually. So we do want to try and personalize things as much as we can. So that's why we do the follow-up calls. So we did do a few with the men. There were quite a lot that just did not pick up their phones, did not engage. So unfortunately, we haven't been able to get some of that feedback yet. With our next cohort, we might sort of brainstorm how we're going to do this in a different way, and start potentially getting some feedback one step before. So everyone gets an initial assessment before they get enrolled onto a program. And if at that stage someone says, no, it's not for me, I don't want to join this, then we want to try and capture it at that point, rather than trying to sign them up, persuade them, and then they not turn up and we never find out why. So just trying to capture the data at all contact points, really.
Brilliant, thank you. And that is such a brilliant question and a brilliant message, because we've heard from speaking to lots of different physios that they're getting so much information when they're following up on their DNAs, and people not coming or not completing treatment. So I think that's a really brilliant message. And I don't know, I'll put it out. I don't know if George or Katie, if you've got any other thoughts on how to engage with people to find out why they haven't come. If you guys have got any experience on that you'd like to share advice on.
It is difficult. I think it's again, it's, as we said, it's using different ways, trying to appeal. And so we have posters across some of the prison sites and the courts and things like that. There's email, there's the intranet, but the more engagement you can get, the better, because it rolls from there. But giving feedback, like George has those testimonials from patients, makes a huge difference. If they see people that they feel they can associate with, that really helps as well. So it's engaging the ones who've been through the process and had success makes a huge difference. So that's probably the best way, because it feels more centered around them.
Excellent. I can see George nodding. I don't know if you've got anything else to add.
I think co-creation is the key thing. It was really important to us when we developed our service and pilot, was to go out into the community to see what they felt they needed, where they needed as well. And one of the things that really stood out to us is that a lot of the people we spoke to didn't know we existed in terms of a service. And those that didn't trust us because of the previous interactions they'd had. So that for us has been really important, is trying to understand how we can meet these people's needs in particular. But yeah, it's a really, really tough one. And we find similar challenges in keeping people engaged and not dropping out. And I think one of the things that to really highlight is that, we're talking a lot about health inequalities, that these people have really, really, challenging lives and competing interests. And sometimes engaging with a health service is the last thing on the list that they need to think about on a day-to-day basis. When you've got people trying to fight the system for asylum, or to try and get food from a food bank and these sorts of things, then the last thing they want is me knocking on their door or ringing them and pestering them. So yeah, I can totally relate and empathise with all of these situations. But yeah, I think for us, co-creation was at the heart of, and what we found to be the most beneficial thing for us.
Brilliant, thank you.
Thank you. Can I jump in with a kind of follow-up question that is linked to that, which, and I guess the broader question is there just something around the need for patient choice in terms of to improve engagement? So using Emily and Emmy, your example of the kind of men's only weight loss program, but is it that they could have the choice potentially of either the group or one-to-one or a mixed class, for example? And so that links to a question that I had put in the Q&A earlier, which is, what are the kind of resource and cost implications? Is there a difference between the holding the kind of male only classes to the mixed, and just whether that would play into that option of being able to offer choice? Very long-winded, sorry.
Yeah, so it's a good question. With our service, we already have the mixed groups, I guess, set up. So when we are thinking about like cost and resources, we're kind of piggybacking on those to create the men's groups. I think when we're thinking about cost and resources for our men's group, originally with the cohorts, they are a lot smaller. As we're getting the ball rolling. So I guess cost would increase for the men's group for that, because men in the venues, men using the equipment, the amount of like staff to patient ratio is slightly higher. So definitely at the minute they do seem a little bit more costly than a mixed group, but it's something that we're looking at, and our current cohort has now got 20 people in it compared to a lot more smaller cohort at the beginning. So we're hoping that that improves, but yeah, it can be quite challenging.
Brilliant. So I think we've probably got time for one very quick last question, which I'm going to ask Katie, if that's okay. Just wanting, if you've got any advice that you can give for anyone who wants to improve how they support patients who have limited digital confidence to really engage successfully in digital physio.
Yeah, well, I just see it as a service. So I think if you start to think of it as a barrier, that's a design issue. So that's our problem, not our patient's problem. So if it seems inaccessible, then we've designed it wrong. So again, it is patient at the heart, isn't it? So, and quite often just having that personal connection to make it easier. So if it seems complicated to them, that means it is too complicated. So you've got to look at it the other way around. So what can they manage? So, you know, some of my patients struggle with even a video link. So we always just call them. You know, it doesn't have to be, you know, it doesn't have to be complicated. You make it as simple as possible. It should be made around your patients. It shouldn't be made because that's what you want to use.
Thank you. I love that message of if the patients find it too complicated, it is too complicated. I love that. That's a really good point to leave the Q&A. Thank you. Sarah, is it all right to get you to just pop the last couple of slides up? So what I just want to do before we wrap up is just to highlight to you some of the CSP resources that we're in progress as a team developing. And we'll have some QR codes that will pop up on the screen in a minute. And if you look in the chat, there's going to be some links into there. Oh, there we go. Perfect. So we are at a bit of a crucial point at the moment as a project team in really updating all of the health inequalities support and resources online. So do check in today, but do check in again. And a really good way of keeping in contact and aware of when everything's being updated is through our ICSP channel, because we will share all of our information in there. And it's a really nice way as well to touch base with colleagues and share any of your ideas with us as a project team. We're in the process of completing our Equity in Action series, where we're looking at access, experience and outcome. And we have series of webinars, obviously including this one, podcasts, frontline articles, all that we're going to share onto the website. And alongside that, we're going to be sharing links to our new Health Inequalities Hub, which is going to be bringing all the useful resources into one place, hopefully in a way that you guys can find it really easy to navigate, because we know from speaking to members that there is so much appetite for health inequalities, understanding more and taking action on it, but people find it complex to navigate. So do check in on those resources and do keep an eye on that over the next few weeks as we update them. And then final slide, please, Sarah. And what we would love to do, because obviously as a project team, this has been a series, but we potentially might be looking to do similar events again in the future. And we want to make sure that they're really useful for you. So please do either click on the link in the chat or click on the QR code. And we'd love to get your feedback and your thoughts on how we can make these work best for you. And so my final thought is just to say a huge thank you to our brilliant speakers, to Emmy, Emily, Katie and George, and also to our fantastic behind the scenes CSP team. So that's Sarah Murrell and Sarah Allen. So thank you so much. And thank you so much for all the brilliant questions today. It has really triggered, I think, a really nice discussion at the end. So thank you so much and take care. I'm going to close the webinar there.